So I'll be presenting a similar sort of case, a bolt from the blue, where the cannula came out. Video. हाँ? हाँ, कर दीजिए वो. You have to be ready so that we don't lose time. हाँ. No, 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 no. It's not there. So this is a straightforward case to start with. I've done the corneal incision, nicked the capsule to do the rhexis. I'll be putting in OVD. This is how I normally do my rhexis. I nick the capsule with the keratome because the flap is raised, and I'm giving in OVD and see what happened. The cannula just came out like a bolt and struck the anterior segment, struck the anterior capsule. So at this stage, I took it out. It was a local loop cannula, but still it came out. So what shall I do? And the patient was having pain. It's under topical anesthesia. What shall I do? So I switched on my retroillumination to assess the injury, and that's what is the Argentine flag sign, where it is extended in both ways. And in this situation, how you proceed depends on the surgeon's expertise, grade of the nucleus, the comorbidity, and also whether to place the lens. If we decide to go ahead with phaco, we have to remember few points in mind, like minimal hydrodissection, minimal rotation, minimum lateral separations, and if we do phaco, try to be in the anterior planar phaco, and always try to maintain the anterior chamber and look for the wraparound extension of the tear, which in flap is a flap motility sign by Rohit Omparkash, and also have a plan B in this situation. Why is not moving? Yeah. So I decided to go ahead with phaco. Whether you do phaco or SICS, you have to have good access to the nucleus. So I had to extend the capsular tear. So nick the capsule on one half with Haldiputkar forceps. Completed the hemirhexis on this side. Now this tear was basically sub-incisional tear. Argentine flag signs normally happens perpendicular to the incision, but here, because it's of accident, it was sub-incisional. In this situation, sometimes it is better to change the site of the incision, but I wanted to proceed on the same site incision and decided to, while doing the phaco, just tilt the phaco tip slightly on the other side. So here I have completed one half of the rhexis and completed the other half of the rhexis and proceeded with the phaco. While rotating the nucleus, you have to be very careful so that no pressure is on the zonules. So I used bimanual rotation, and phaco also you have to be gentle with minimal lateral separation. And again, while rotating the nucleus, you'll notice I'm using the phaco tip as the fulcrum and then using the chopper to rotate against the phaco tip so that no pressure is on the zonule, because in this situation, any pressure on the zonules and the tear can extend posteriorly. There are several ways of doing it. You can take a small pie and do the, then it will give more space. But I decided to do small fragments of chops, gently rotating the nucleus. And once I got the chops, I took the nucleus out one by one very slowly. It's better to use low setting in this situation. And once the phaco is done, you again reassess whether the tear has extended, because the placement of the lens will depend on that. And never allow the chamber to decompress. So this is how you put before taking the phaco tip out, you have to put viscoelastic in the anterior chamber. So IA should be gentle as well with sideways movement, and you have to be very careful where the tear has extended. So I had good rexes on 2 hubs, so I decided to put in the bag lens, and also I didn't have actually the option of 3-piece multi-piece lens on that day. Otherwise I would have probably put the lens in the sulcus 3-piece lens. So I put the lens and rotated the lens in a way where it's not on the extension, and completed the case. Thank you.
Very well demonstrated by two very efficient surgeons about accident which can happen to all of us, not only in phaco but even in SICS of hydrodissection. So I would come to our expert panel, Dr. Vaishali ma'am. Vaishali ma'am, what amount of this was done in visco mostly, and for Sugato it was in hydro. So what precaution would you take? Already Dr. Sneha Jain has told us, so the amount of force, the amount of fluid, she has told us some steps that we have to look into. Please, can you have some expert comments from you also?
Mine also was during the
Visco. Oh, so this was again in the visco stage. So the amount of visco or the cannula, would you have some suggestions on that?
Thank you, Dr. Sudipta, and let me first congratulate both Dr. Sneha and Dr. Sugato for excellent managing because we tend to become so panicky in this situation. So it's easier said than done that, okay, don't panic and all, and both the cases were excellently managed. I would just I thought, I don't know what I would have done in that case, but in Dr. Sneha's case I think there was a bit of over pressure due to the fluid, forceful, yes, which caused the nucleus to pop up, whereas in Dr. Sugato's case it was very well managed, and I like the one who dares finally be successful. So I really congratulate you for completing the rexes as well, because it he has very well said that the surgeon skill also matters. So I would say that those who are beginners, or they better not try in a Argentinian flag sign. So it's better to avoid what usually is done to be on the safe side. Yes, convert, do an SICS is equally good. But hats off to Dr. Sugato also for completing the rexes. I felt that was really great, and the overhydration in the first case. That's all. Thank you.
Thank you, ma'am. And from Dr. Nayana, we would like a word from you also regarding Dr. Sneha Jain's case.
Right. Okay. I think she has handled it very nicely. And as Dr. Vaishali said, there was no panic scene in the moments also what she was doing. And
would you have suggested, she had retrieved it by SICS, would you have suggested putting in any tricot and then looking into it if there was any, she did, if some vitreous was there in the anterior chamber?
No, it is not mandatory to put tricot. I think it's not mandatory. And one thing I would like to say, sometimes in a hurry we push the visco very fast. Correct. So it should be pushed in a graded manner. You bring the visco to the tip and then introduce into the anterior chamber, and then with grade allow it to disperse and then push. I think that will take care. Okay. Secondly, I also tell my residents to reconfirm whether the lock is properly put. That is the most important thing, because the sister or the staff, they in a hurry, they may not have secured it so well. And another important thing which I feel this can happen is that the entry is too small and you are struggling to enter with the cannula. In that case, this can also happen. Then once you enter, you push it very vigorously. So the side port or the incision has to be adequate. I think that will also help.
Thank you, ma'am. And can we have, yes.
Just one last thing that I noticed, that in not only about the rexes and this, but also there's a chance of dangerous of hurting the corneal endothelium as well, because it just spurts, and then so that care is also to be taken. Proper OVDs are necessary.
Can we have a word from the chair finally to sum up the case?
Okay, not to sum up the case, but I just thought Dr. Sugato was in the wrong hall in the wrong time. You should have been in the hall F at 2:30. That's where court martial begins, yes. So, yes. So So I think excellent management, Sugato, and these things will happen maybe once or twice in a lifetime. But one thing that, for our younger colleagues, I would say that uh, the it was a lower look syringe, but even if it is not a syringe with a lower look, then also 2 fingers on the hub is mandatory. And all of us have saved by a pinch of those 2 fingers while injecting so many times. The sisters in a haste would have not given a tight screw to it, and then this can be a miss. But that 2 fingers is very important. Number two is, all of us, especially in our hospitals, we should have a library of lenses, of 3-piece lenses, which I think becomes mandatory not only in such cases of accidents, but also for PCRs as well. So at times it's not possible, but that would be a very, very ideal situation.
Thank you, sir. Yeah, there's a question from the audience, I think. So yes, Pranab. Okay, I think, yes, anyone of you can take up that question if you want.
Okay, I'll take up these questions. If your cannula, if it hits the base of the iris and if there is a bleeding, if it's a spontaneous, if it's a huge bleeding, you cannot do anything except that, you have to keep the eye tight and you can inject good amount of OVD. You sit there and wait till it pauses. Then again, maybe after 30 seconds or maybe 50, 60 seconds, you go ahead again, wash it out and just see again. And again, if you have a bleeding, again, then you have to inflate it and wait. That's what actually I do. Secondly, you had a second question where you place the haptics. The haptics, if you have a cut like this, you need to place those haptics like this. It should be perpendicular to that. For the first case, I just had one more question. I don't know if I missed it, I don't know. You had a dangling nucleus, right? And you then converted it into an SICS and you explanted. I just missed, what lens did you put inside? You, okay, you placed. Okay, perfect. I think that's pretty good. An alternative to that, what I would have done alternatively would have been, levitating it into the anterior chamber, and because your anterior capsule was intact at that point of time. So I would have just taken a 3-piece intraocular lens and injected beneath that because your lens was not very hard. So IOL scaffold could have been done very easily. You could have, dialed the same IOL and then. You started with a small incision. Okay, then it is fine. Then you already have an incision, so you ended up with that. So I think that sounds good.
Can I have a quick question to the expert panel? Like, in this situation, if you are putting a single piece lens as I did and place it perpendicular to the thing, is it better to use hydrophilic lens than hydrophobic? Because if the hydrophilic lens haptics comes out over the anterior capsules, they cause less damage, or they rub against the iris less than the single piece hydrophobic lenses. Is it so?
Sugato, not really, I think, single piece lens with its malleability and the pliability will always occupy less space, whereas if it has to go into the sulcus, it should be a 3-piece lens.
Thank you.
Absolutely.
So I'll call the next speaker.
Another one thing that you had asked about how to manage the bleed, even putting simple air will also help in bringing down the bleeding, and you can, well, yeah, it will cause a tamponading, and that also can help.
I'll tell you, I'll quickly tell you. See, air, as madam said, if it is a very small bleed, maybe it can take care. But if it is a profuse bleeding, which could have had in Sugato's case, it will bleed and bleed and bleed. And especially if the base of the iris has been detached, that bleeding will not stop very quickly. So viscoelastic, and not only methyl cellulose, if you have high molecular viscoelastic, give it a good push and make sure the pressure with your finger pressure is tight. It should be tight. And what we, as surgeons want to do is want to go over the situation quickly. Let at least 2 to 3 minutes elapse by the clock. then only try and remove the visco and see that if it is bleeding. And what someone said, that again refill, if it is still bleeding, most of the time it will stop.
I had one of the case till now, since so many years I had one case where I had to abandon the surgery because of high FEMA. There was no way it was going. I waited for so many minutes and it was just not going. I just winded up, took a Teno suture, closed the incision, and I started the patient on drugs so that the pressure does not rise. I told the patient was on other anticoagulants and everything. So I just explained to the patient that, look, you are having this. I am going to put a lens in your eye, but give me few days. I waited for 3-4 days, and then there was a big clot which formed, and then I took the patient. I just very carefully I removed that clot, and then I placed the intraocular lens. So once I had to abandon the surgery also.
You know, this is very good discussion. I'll just
Thank
give
you
one
so
small,
much.
because the clot, dislodging the clot at that point of time is not judicious at all. The clot has sealed it. So, you know, taking of the clot again will rebleed. So even if there is a clot, let it be. Put in your lens, just give a good wash and go ahead.
Thank you.
And
Thank you